This is a really weird talk. But some things have not changed. And one of the things when we first did this course, I think it was 23 or 4 years ago, I looked at the in-service exam and there were 250 questions and 23 of them were on vitamins, either deficiencies or intoxications. Unfortunately, that has not changed. It's not quite that big a percentage. But there are certain things that you have to know for boards that you probably don't really care too much about. But they're easy to test on, and therefore you need to know them. So we'll go over most of these things, and I'll point out have shown up on the. I've continued to look at in-service exams and pick things off to think, oh my Lord, they're testing this question, they're going to use it on the boards. And usually 3 or 4 years later, something shows up. And so it's a sort of a potpourri. Hopefully you'll be able to recognize the vitamin stuff. We'll talk about polycystic kidney disease and the huge variety of other things that sort of show up. MP was a 5-year-old girl who presented to her pediatrician at 6 months of age with abdominal masses. At 18 months of age, she had developed seizures about 5 days following her DPT booster. She is severely developmentally delayed. This is her renal ultrasound. This is her CT scan. So it's a developmentally delayed 5-year-old with seizures that looks like this. Her renal ultrasound and her abdominal CT scans were just shown. What do you think the diagnosis is? Infantile polycystic kidney disease, adult polycystic disease, tuberous sclerosis, or multicystic kidney disease. Key in an answer. Infantile polycystic kidney disease. Wrong, but this is okay. These slides were actually used at the National Pediatric Urology meeting, and it fooled most of the urologists who actually thought it was adult polycystic kidney disease. And in point of fact, what's the best study to confirm your diagnosis, which turns out to be tuberous sclerosis? And these are huge angiomyolipomas. So what would be the best, if you thought, oh, maybe this child has tuberous sclerosis, what would be the best test? Key in an answer, please. CT of the brain. Exactly right. And there it is. And you see the calcifications there. And that's just classic for tuberous sclerosis. Tuberous sclerosis is a disease, and the hints were obviously the development delayed in the seizures. They usually don't have tubers anywhere near that big, angiomyolipomas, but they can. And now there's medical treatment for those with rapamycin, which actually limits the growth of those tumors. And the danger of the tumors is, and this particular girl did exactly that, they can bleed into them and have serious problems. She put a unit of blood into one of those things at one point. But that was in the old days prior to surgical correction and or rapamycin therapy. Okay, MG. A 3-year-old girl referred to you with increasingly severe headaches, which is, you probably know, is unusual for a 3-year-old. On physical exam, you note that there are a number of cafe au lait spots, at least 3 by 5 centimeters. Father has lesions on his trunk and has a lumpy tumor at the base of his wrist. On physical exam, her blood pressure is 150 over 110. The likely cause for her hypertension is coarctation of the aorta, Conn syndrome, renal artery stenosis, or multicystic kidney disease. Please key in an answer. Bingo, right. What has she got? Her original disease is a sort of classic boards. You're supposed to recognize one. This is a patient with neurofibromatosis, NF1. And what are the causes of hypertension in NF1? Renal artery stenosis would be the top cause for a child. Interestingly enough, if you were an internist and you were dealing with a 30-year-old with exactly the same thing, the answer would be pheochromocytoma. They have an increased incidence of renal artery stenosis and pheochromocytoma. Renal artery stenosis is more common in children by almost 20 to 1, and pheochromocytoma is much more common in adults who have neurofibromatosis. But it's characterized, as you can see, you can't see the stenosis very well, but it's right there. But you also can see the aorta is somewhat tapered. They also get optic gliomas and neurofibromas. That's the bumpy lesion on the wrist that the father had, was probably a neurofibroma. And optic gliomas need to be looked for. Okay, a 13-year-old girl also has a history of increasingly severe headaches for 2 months. Headaches are frontal in location, pounding, have awakened the child from sleep 3 times in the past week. Physical exam reveals a blood pressure of 110/70. She's a bit hyperreflexic, but symmetrical. She has mild hepatomegaly. Which of the following is like a likely clue to the etiology of her headaches? She was in an auto accident 4 months previously, after which she had a normal CT. She's grown 10 centimeters in the last 7 months. Teachers have noted that she's very distractible. 6 months ago, she became a vegetarian and began vitamin supplements. She takes tetracycline once daily. Good. I gave you the hint. Vitamins. Given the historical fact that she is on vitamin supplementation, particular attention should be paid to which one of the following? Key in an answer, please. A, correct. The first of many. Vitamin A, fat soluble, deficiency signs, poor night vision, dry eyes, xerosis of the conjunctiva or ptosis spot, which is actually a small gray spot in the eye, which is dried conjunctival cells. Toxicity, headaches, pseudotumor cerebri, dryness of the mucous membranes, and the hepatomegaly. The hepatomegaly and the hyperreflexia were 2 hints that this was vitamin A. Possible polycystic disease. You have to, I'm not sure, after I submitted these, I was looking at them last night. Line 3 is the first one. A worried mother brings 2 sons to you because she's worried. They are 5 and 7 years of age. Her concern is that her father's brother has just started dialysis and has adult onset polycystic kidney disease. Her father was seen and had a normal renal ultrasound. Which of the following studies should be done to relieve this mother's concern? Please key in an answer. Again, most of you got it right. None of the above. Why is that? The reason is it was her father's brother has polycystic kidney disease. That's an autosomal dominant. Her father had a normal renal ultrasound. Therefore, he doesn't have the disease. Therefore, he didn't give it to mother, and therefore the sons don't have the disease either. So you do the relatively simple genetics and say, this is okay. The reason I chose the father is sometimes patients with polycystic kidney disease may not show up with cysts until they're 15 or 20. Sometimes as late as 30, but usually by 15 or 20. So, but if somebody who is age 40 or 50 does not have cysts, they're not about to develop them. Okay? Speaking of polycystic disease, you were asked to see an expectant mother for prenatal counseling because the fetus has been noted to have 2 very large kidneys that take up almost the entire abdomen and appear to be encroaching and preventing lung development. Mother wants to know if her child has polycystic kidney disease, and if so, what problems her babies might have. Which of the following are true? The baby will most likely be born with renal failure and require immediate dialysis. Severe respiratory distress in the newborn period is likely. The risk of other children being affected is 50%. Older children with infantile polycystic disease may develop signs of hepatic fibrosis. And cerebral vascular malformations are often seen in patients with infantile polycystic kidney disease. Please key in an answer. Bingo. Actually, D is also true. Older children with infantile polycystic disease may develop hepatic fibrosis. That's usually seen in the teenage years, and then they develop, with hepatic fibrosis, they may develop esophageal varices because of back pressure. And so you need to screen for that. But the point is that many babies are not born in renal failure. The critical variable is whether or not they can be ventilated. And most children who die very early in life, in the first month or two, it's usually a problem that the kidneys are so large that you have very significant pulmonary hypoplasia and inadequate lung maturation to sustain life. Polycystic disease, infantile, it presents in infancy. Usually you can often see it in utero. Hypoplastic lungs are common. It's associated with congenital hepatic fibrosis, which is usually much later. And it's an autosomal recessive, so it's a 1 in 4 chance. The adult type, cysts may be present early in life. I've actually made the diagnosis of adult polycystic disease in utero once because the child had cysts. There was a family history. And the kidneys weren't big, they were just multiple cysts. Symptoms are usually 40 to 60 years of age before they develop renal insufficiency. There's a 12% association with baryaneurysm, and that's important for pediatricians to know. And it's autosomal dominant. Why do you have to know about 12% association with baryaneurysm? It tends to run in families. So if you have a family history of autosomal dominant polycystic kidney disease, and a 5-year-old begins complaining of commode-hugging headaches, you need to think about it. Because, as you know, young children don't complain of headaches that often, but a baryaneurysm that starts to leak a bit can actually be a significant cause of headaches. And those are now fixed. One, that you can find them on MRA, and number 2, they can be fixed. They can usually be clipped and disasters prevented. So you need to be aware of that. Even though the child is probably not going to have a problem with renal insufficiency anytime during the time a pediatrician is caring for them, but they may have difficulty with headaches. The other thing that they may well get, is anybody who takes care of these patients knows, is they may have hypertension. And even children with polycystic kidney disease will sometimes have significant hypertension earlier in life and have to be treated. That pretty much says what I just said. The one thing that's new that probably won't be on the boards is it's pretty clear that if we could stop the cysts from growing, that we can probably preserve renal function. There are a number of drugs in trial currently which seem to ameliorate the cyst growth. And so I'm more optimistic than I had been in the past, and I actually try and follow these patients every year. The other thing we tell them to do is not to drink, is to avoid caffeine. Caffeine increases sodium potassium ATPase, which is actually puts more fluid into the cysts, at least in tissue culture. And we want to do everything we can to prevent cysts from growing. This is always on the boards in some way, shape, or form. And I've done this for 40 years and I've seen one case. But this is the first case that was described. A 13-year-old mentally retarded and institutionalized child with tuberous sclerosis is brought to your office with swelling of both wrists and appear painful when touched. There's no erythema or fever. X-ray studies show widening of the epiphyseal plates and fraying. Which historical factor is most important? History of milk allergy, family history of osteoporosis, a seizure disorder controlled with Dilantin, history of stopping multivitamins 3 months ago, or previous history of a fractured rib. Please key in an answer now. Bingo. This is a sharp group. This is actually the first case of anticonvulsant-induced rickets. Dilantin and or phenobarbital both accelerate the breakdown of vitamin D125. And this story is actually the one that was there. And what they did, which appalls me at this point in time, is they didn't treat the girl with vitamin D, they stopped the anticonvulsants and showed that the rickets got better. Now, I've only seen anticonvulsant-induced rickets once in my life, but it's always on the boards, and it's Dilantin and phenobarbital. So now you know. You're going to get more on this in the calcium phosphorus talk, but just to go over it, deficiency rickets. It's A fat soluble. It's swelling of the joints. Actually, you get widening of the growth plates. You get frontal bossing in infants and obviously bowed legs as they begin to stand. They have less tensile strength. Vitamin D intoxication, which is also, and actually you do see this when parents sometimes get the wrong vitamin D preparation, is hypercalcemia, nephritis, interstitial deposition of calcium, which is nephrocalcinosis, hypercalciuria, and headaches. All right, and this is a patient that I saw, I think it was 2 days after the first board review course. You were asked to see a patient for a preoperative evaluation for correction of ptosis. Had previously had an orchiopexy, is less than the 5th percentile for height, and has a webbed neck. On exam, a mid-systolic murmur heard over the entire chest and pronounced over both sides of the back. You conclude he has Form-Frust-Turner syndrome, probably has peripheral pulmonic stenosis, has Russell-Silver syndrome, most likely has Noonan syndrome. Please key in an answer. Most likely has Noonan syndrome. Correct. Noonan syndrome. I don't know if George covered this or not, but pectus excavatum, webbed neck, short stature, mental retardation. The congenital heart disease is usually peripheral pulmonic stenosis or septal defects. They also have a history of ptosis, hypertelorism, and epicanthal folds, and oftentimes they have testicles that need orchiopexy. So it all fits. But that's Noonan syndrome. You know Russell-Silver syndrome. I know George covered that. The short stature is obvious even prior to birth. Small triangular face. asymmetry of the limbs, the small incurved little finger. Oftentimes they end up being evaluated for a large persistent fontanelle or delayed closure of sutures. And at least last time I talked to George, unilateral, getting 2 copies of the same chromosome. 7 is associated with about 10% of them. Neck mass. A 13-year-old girl is seen for routine physical exam after having moved from Egypt. In the past, she'd had 3 episodes when she developed swelling in the middle of her neck. It had become red and exquisitely tender, and her symptoms resolved with antibiotic therapy. On exam, there's a small mobile mass just above the hyoid bone in the midline. The mass actually felt fluctuant and moved up and down when the patient stuck her tongue out. This is the mass. And that's in the middle of her neck. The most likely diagnosis for this is a brachial cleft cyst, follicular carcinoma, early lymphoma, or a thyroglossal duct cyst. Correct, thyroglossal. I actually did see this patient, and it surprised me because she'd been seen in London for 3 times for that and treated with antibiotics for the previous when it got infected. But it's an easy thing. I think I answered. Thyroglossal duct cysts, they are midline. They're migration of the thyroid tissue down from the base of the tongue. And therefore, when you stick your tongue out, the mass will often move because it's often still connected. Brachial cleft cysts are laterally, and they can be huge, they can be small. And thyroid carcinoma wouldn't be present for years, nor would lymphoma. Abnormal thyroid screens. State Department notifies your office that a newborn screening test revealed a high TSH on a patient who is 7 days old. You should obtain a TSH and a free T4, obtain a thyroid scan, begin thyroid replacement therapy now, obtain a skull film to assess the sutures. Please key in an answer. Correct. A, confirmation screening tests are necessary. Treatment can be delayed 24 hours. Thyroid scan should be done only if there's a diagnosis of hypothyroidism is confirmed. Prolonged open sutures are a sign of hypothyroidism, but they're not helpful in the first 7 days. Assuming your laboratory studies confirm hypothyroidism, which study will most likely reveal the etiology? A T3 resin uptake, a thyroid scan, an I-131 uptake with perchlorate, or thyroid binding globulin determination. Good. We'll talk about the thyroid binding globulin. But a thyroid scan is the most likely. 60% of congenital hypothyroidism will have an ectopic thyroid tissue, and another 30% you just won't be able to find it. So that accounts for about 90% of them. A T3 resin uptake really doesn't help establish the etiology. 10% will have metabolic defects determined with an I-31 uptake studies. So that would get the other 10%. A deficiency of thyroid binding globulin, for those of us that are, I see at least a few people with gray hair. In the old days, we'd get just a total T4. And it would turn out that the free T4 was normal and the TSH was normal. Now you get the free T4. Doesn't represent true congenital hypothyroidism, but rather an absence of binding protein. And because so little thyroxine is bound, the free thyroxine is normal. But if you measure the total T4, you end up with a low value. And studies would show a decrease in the total T4, but a normal free T4 and a normal TSH, which is why you get free T4s when you do this now. Treatment is not necessary with thyroid hormone because the free T4 is normal. This was actually a question on my internal medicine exam a long time ago. A 17-year-old is referred for evaluation of a heart murmur on his pre-college exam. He has noted decreased stamina when playing basketball. On exam, he's a muscular kid, mild perioral cyanosis, and bluish nail beds. There's a grade 2/6 holosystolic murmur, and his blood pressure is normal at 130/80. The most likely diagnosis is tautology of Fallot, atrial septal defect, ventricular septal defect, truncus arteriosus, or Wolff-Parkinson-White. Please key in an answer. Ventricular septal defect is part of the answer because A is actually the answer. Now, why is that? Tautology of Fallot is the most commonly diagnosed cyanotic congenital heart disease later in life. And what's happened? In terms of what happened is you have pulmonary stenosis and a VSD. But if the pulmonary stenosis is not very pronounced, things may be relatively normal, but as the pulmonary stenosis gets tighter, you begin to shunt across the VSD and show cyanosis. And every once in a while, the diagnosis of tautology of Fallot is made late. So they don't have pulmonary hypertension because of the stenosis, and as it gets more and more pronounced, they begin shunting right to left, and then you begin to see cyanosis. So the congenital heart disease that's most often diagnosed later, cyanotic, is tautology. This is always on the boards too. Indications for immunotherapy for bee sting prophylaxis include which of the following? Cardiovascular collapse, large local reaction, respiratory distress, generalized hives, joint swelling. Please key in an answer. Okay, good. Cardiovascular collapse and respiratory distress. Those are the two. This in the old days, they used to say A and C, B and D, A, B and C, da-da-da. But in terms of, the point is, large local reaction, joint swelling, anything local is not an indication for immuno. Systemic reactions, respiratory distress, and cardiovascular collapse are indications for immunotherapy. Okay. Night terrors. All of the following are characteristic of night terrors except the child appears terrified but cannot be awakened. The child cannot remember the episode in the morning. Common in children ages 1 to 8. Children may have eyes open during the episode but appear to look right through you. Child awakens suddenly 5 or 6 hours after going to sleep and may be screaming or talking wildly. Which one of those is not characteristic of night terrors? Please key in an answer. Correct. When does it usually happen? It usually happens early, like 1 to 2 hours. And just to digress briefly, I got a call from my oldest son about, it must have been 17 or 18 years ago. He says, my God, my son just woke up and he described A, B, C, and D, and actually part of E, wildly. And he said, what the hell's going on? And I had given him a book by Bart Schmidt, who had, and subsequently the American Academy, in terms of raising your child. And it was very good on child development. And I said, PT, get Bart Schmidt's book, look up night terrors, read it, and call me back. And sure enough, but it is truly terrifying in terms of, as a parent, to see this, because you're convinced they're possessed by the devil. Whoops, wrong one. But they usually occur in the first 2 hours so the parents are awake. 6-year-olds referred by a school teacher. A patient often loses concentration for periods of 10 to 15 seconds, then resumes activity. Frequency of these episodes is increasing, and she may have 12 to 15 of these in an hour. On exam, she appears normal, as is the rest of her physical exam. The patient will most likely improve with Ritalin, require behavior feedback, have an EEG with 3 per second spike in wave pattern, or respond to Dilantin. Key in an answer. Correct. This is the classic board approach. You're supposed to know she has Pennymal, and you're supposed to know what the EEG shows. And what would she respond to? Valproate is one, and I think ethosuximide is the other, but not Dilantin or phenobarbital. And that's the classic EEG. I don't think they'll show you an EEG, but that's the classic EEG. Recurrent infections. A 3-year-old is referred for recurrent skin infections, 4 episodes of cavitary pneumonia, and numerous episodes of lymphadenitis. That's all you know. The most likely diagnosis is one of the 4. Severe combined immunodeficiency, chronic granulomatous disease, X-linked hypogammaglobulinemia, or adenosine deaminase deficiency. Again, most people got it right, chronic granulomatous disease. Both severe combined immunodeficiency and adenosine deaminase deficiency present very early in life with absolutely overwhelming infections, both viral and bacterial. X-linked hypogammaglobulinemia patients are prone to a variety of bacterial otitis media, pneumonia, sepsis. Okay, so that's chronic granulomatous disease. A 13-year-old with swelling. 13-year-old girl presents with a history of swelling of her eyelids and feet for the past 2 weeks. Her physical exam reveals a blood pressure of 130/100 and 1+ pretibial edema. Urinalysis shows 2+ protein, 2+ hemoglobin, a microscopic exam that reveals 2 red cell casts per high power field. Blood work includes a serum creatinine of 1.0, a BUN of 29, a CA3 of 35, normal being 70 to 150, and a hemoglobin of 11.2. Possible diagnosis include all of the following except systemic lupus erythematosus, acute post-streptococcal GN, membranous proliferative GN, or IgA nephropathy. Again, most of you got it right. A glomerulonephritis with a low serum complement is one of 3 things. And to be socially incorrect, one of my residents says, oh, I just think of PMS. Post-streptococcal glomerulonephritis, membranous proliferative, or lupus. Interesting enough, two of those 3, membranous proliferative and lupus, are very unique diseases in that they're more common in women than men. Almost every other renal disease is one more common in men and more serious in men, except those two. So if you see a low complement, it's one of those three diseases. Auto accident. An 8-year-old boy seen in the emergency department following an auto accident. He was not wearing his seatbelt, was in the front passenger seat when he was struck by a vehicle on the front passenger door. On exam, he's pale, in moderate distress with rapid shallow respirations. Blood pressure is 130/80. He has a laceration of his right arm and glass particles embedded in his right cheek. Chest X-ray reveals 3 fractured ribs on the right and no pneumothorax. Urinalysis shows 3+ blood, negative for protein. Microscopic exam shows numerous RBCs, but no casts. The next study should be A, renal ultrasound, B, a KUB, C, an intravenous pyelogram, or D, an abdominal CT scan. Please key in your answer. Bingo. Blood in the urine signifies that obviously there's severe trauma. Major concern is not the kidney, actually. Even if the kidney is lacerated, in most cases, you will put the child at bed rest, give supportive therapy, and in many cases, you don't have to do much else. However, if the liver is lacerated, that's disastrous, and that needs immediate surgical attention. And because it's obvious that there's been major trauma, you need to look at not just the kidneys, but the liver. And so you're really more concerned about the liver on the acute situation than you are about the kidney, and so the abdominal CT scan will show you both. Oh God, they say vitamins. Here we are. Match the deficiency with the symptom. Okay, vitamin A. And this is not the way you'd do it. You'd probably look at which one you know to start with and then eliminate the rest of them, but you're going to. Short-term memory question. We talked about dry eyes. Vitamin C. And this is hard, and it won't. Well, this isn't the one that's hard. That was the next one that's hard. Yeah. Okay. Bleeding in the joints. I think everybody, well, at least most people, have at least heard the story about in England on long sails in the Navy. They often had patients who developed bleeding in their joints and mucous membranes. And then when they discovered they thought it was vitamin C, they sent 2 boats out. One crew had limes, lemons, and oranges, and the other didn't. And lo and behold, after a 120-day cruise, one ship had patients who had significant joint problems and the other did not. Vitamin D, deficiency. Right, they'll have growth failure. This is the classic patient who develops rickets. Low calcium, low phosphorus, and actually slightly low bicarbonate, but okay. Vitamin E. Anemia, and vitamin K. We won't have them key this one in, seeing so there's only one left. But I think bleeding in the GI tract of a 1-day-old, that's pretty obvious in terms of they need their vitamin K. Hypoglycemic infant, a 6-month-old, presents to the emergency department with sudden onset of tremors, vomiting, and poor responsiveness. He was breastfed exclusively and is now just beginning to take a bottle that has begun fruit juices. His blood sugar on admission to the ER is 22. Abdominal exam is unremarkable. The most likely diagnosis is galactosemia, hereditary fructose intolerance, nesideroblastoma, and glycogen storage disease type 1. Hereditary fructose intolerance. This is something that wasn't much seen before the 1980s when they began using fructose in fruit juices and in, actually most sodas are now fructose. They used to use sucrose. This child has just started fruit juices which are fortified with sucrose. Other features of it are failure to thrive, hepatomegaly, and aminoaciduria, but most of these patients are going to develop significant problems early. And obviously being breastfed, he was getting lactose. Lactose is his major sugar and wasn't exposed to fructose until he started the fruit juices. Galactosemia would present earlier. Breast milk contains galactose, and the child would have been symptomatic. Type 1 glycogen storage disease also would have presented earlier, and there would have been hepatomegaly. And nesideroblastoma is possible and usually presents during the first year of life. That has to be considered. Measure an insulin level. This actually happened to me once. You are called by the state lab on a Friday afternoon with a positive result on an infant screening for galactosemia. The baby's now 8 days old, has been formula fed since birth. What physical finding would you not find in this infant? Hepatomegaly, cataracts, lethargy, hypotonia, cardiomegaly. Please key in an answer. Again, cardiomegaly would be the one that you wouldn't see. Surprisingly, cataracts, hepatomegaly are relatively rapid. And at 8 days of age, you're not going to see huge cataracts, but they could be found. Which of the following would be most helpful to determine if he's really got it? A blood glucose determination, liver enzymes, a PT and PTT, a urinalysis, or a urine for reducing substances? Bingo, urine for reducing substances. My memory of this disease is, this is embarrassing because I'm so old, but I was in North Carolina I think it was 1972. And a family practitioner from eastern rural North Carolina, the middle of bloody nowhere, sends in a child with the following thing on a script. This child has galactosemia, please diagnose and treat. And I called him and he said, well, and he named a few symptoms. And he said, so I did a urine for reducing substances and it was positive. Of course he's got galactosemia. And of course he was right. So as a real smart intern, I was showing something. Which of the following, and this was a practical question. You've got him, he's Friday afternoon, he might have galactosemia. Which of the following do you feed him? Enfamil, Isomil, Good Start, Similac, or breast milk? Key in an answer. Our gastroenterologist actually asked this question to our residents yesterday. Good, most people got it right, and I think they know why. Isomil uses sucrose as their sugar, which is glucose/fructose. All other formulas in breast milk have lactose, which is glucose-galactose, as the carbohydrate source. And it's the inability to metabolize galactose that results in symptoms. So of those formulas, it has nothing to do with the fact that it's soy protein. It has to do with the sugar that's used to fortify the formula. If he's not treated, the most likely outcome would be mental retardation, death secondary to liver failure, seizure disorder, or death secondary to E. coli sepsis. And people got that right too. I don't know why, but with these metabolic diseases, E. coli sepsis is the bear. And most of them would die of E. coli sepsis if they were totally untreated, usually within the first year of life. Waardenburg Syndrome. Which of the following is not correct with regards to Waardenburg? It's inherited as an autosomal dominant. Patients often exhibit a broad nasal root. Sensorineural hearing loss occurs in about 20%. The incidence of mental retardation is 50%. Please key in an answer. Actually, the incidence of mental retardation is much lower. So that's the right one. It's easy for me to remember only because one of my fellow residents had Waardenburg's, and we used to give him a hard time. And he did not have hearing loss. But mental retardation is not really. Match the following. Chronic hypervitaminosis A. That's a pseudotumor. Vitamin D toxicity. This is where you have to look at the others two first. Bingo, nephrocalcinosis. Vitamin C toxicity. 50-50 shot. Yeah. Kidney stones. High-dose vitamin C patients would get kidney stones, and we won't do the last one. Acute vitamin A can be anorexia, pruritus, and poor weight gain. So, again, this is way overdone, but this is what shows up. Okay. A 14-month-old is seen in the emergency department for severe abdominal pain and found to have constipation. Was given a Fleet's enema sodium phosphate without a result, so it was repeated. 30 minutes later, the second enema was given, and he developed a grand mal seizure. This will be on the boards in all probability. The most common likely cause of the seizure was hypoglycemia, hypertension, hypocalcemia, hypophosphatemia, or pyridoxine depletion. Hypocalcemia. Secondary to acute phosphate overload. That's why we try not to use phosphate enemas in babies. Is the phosphate through the enema can be absorbed right across the colon. As you will hear in your calcium phosphorus talk, the phosphorus goes up, the calcium drops. It's a teeter-totter. That provoked the seizure. Saline enemas are preferred, and phosphate enemas should be used with great care or avoided altogether for that reason. It was interesting because I've had this on the board review for years, but about 4 years ago, somebody came in the emergency room with exactly this story, and the residents drew PTH as well as everything else, which I'd never even thought of. It was fascinating to me because the PTH, and this was probably less than an hour after the hypocalcemic incident, was was about 500. And 24 hours later, it was 50, which is just slightly above the normal range. The PTH response is incredibly fast. On a normal newborn exam, you know that the baby is larger on the right than on the left. Arm, leg, and trunk are all involved. The baby has an increased risk of all of the following except Wilms tumor, hepatoblastoma, adrenal carcinoma, acute lymphocytic leukemia, or adrenal adenoma. Bingo. Acute lymphocytic. Wilms tumor, hepatoblastoma, and adrenal tumors are all more common in hemihypertrophy. Ataxia, a 26-month-old has been walking since the age of 12 months, is brought to you because the gait's not improving, but rather is less steady than he was at 21 months. You note that he has bloodshot eyes, and parents say he's always is like this, that although it may be getting worse. The infant has a disorder which is characterized by all of the following except a susceptibility to sinopulmonary infections and increased incidence of basal cell carcinoma and lymphoma, severe thymic hypoplasia, progressive jaundice, or a decrease in IgA and IgE levels. First, you got to know what he's got, and then you have to know what the characteristics are. And most people got it right again. What does he have? Ataxia telangiectasia, autosomal recessive condition, sinopulmonary infections, development of multiple telic changes, a very high incidence of neoplasms, most common of which is lymphoma. Okay? This is my daughter, who's unfortunately now about 38, but at 3 years old, she returned from vacation and found her Flintstone vitamins in the suitcase with iron, and she ate them all. Okay? She will most likely develop which of the following? Bingo, diarrhea. Iron intoxication. The classic one is not getting your Flintstone vitamins, which has a relatively small amount of iron. The classic one that causes major issues are if the child gets into their mother's prenatal vitamins or prenatal iron. And if they eat that, that can be catastrophic GI bleed. And so iron intoxication is significant. An 18-year-old who's recently been found to have cystic fibrosis is found to have absent deep tendon reflexes, a positive Romberg sign, mild tremors, and inability to direct his gaze upwards. He most likely suffers from zinc deficiency, vitamin B deficiency, vitamin C deficiency, vitamin E deficiency, or iron deficiency. Vitamin E, right. Following all should be supplemented in patients with cystic fibrosis except. Key in and answer. I've got 7 minutes left. Okay, except pyridoxine, right. Fat. The fat-soluble vitamins, and then just pyridoxine's water-soluble. Just remember the geek that talked to you, and remember DEAK, D-E-A-K. Premature baby, born at 35 weeks, is noted to have macrosomia with a birth weight of 4.9 kilos, a large tongue, and a crit of 67%. The baby will have all of the following except a very large adrenal glands on CT or MRI, a tendency towards hypoglycemia, an increased chance of developing Wilms tumor, or a life expectancy of 20 to 25 years. Please key in and answer. Good. He has Beckman-Wiedemann, premature. They have large tongues. Adrenal cortical cytomegaly is a constant feature. Increased incidence of Wilms tumor, which I think most of us realize. And those children who survive childhood do well. Fallacies are more commonly seen in these babies, and affected individuals survive infancies are generally healthy. Hypoglycemia is a problem during infancy, has to be recognized and treated aggressively, usually in the newborn nursery. This is one of those questions that I can't believe is actually on the boards. It was on the in-service exam about 10 years ago, and I said, my God, they're going to put this on the boards. And sure enough, it showed up on the boards. A 3-year-old child is seen because he developed progressively severe symptoms as listless and irritable. About 6 months ago, he developed pink fingers and toes. Now his hands, feet, and nose are pink. He complains of pain and itching of his hands and feet. He's sweating profusely and constantly. He lives on his grandfather's rural farm in rural Mississippi. He most likely is suffering from which of the following: linoleic acid deficiency, lead intoxication, zinc deficiency, mercury intoxication, or copper deficiency. God, you even got this one right. Mercury intoxication. God knows why they put this on the boards. This was seen in the 1950s, and even I'm not that old, which is why I put him on, and they used to use mercury in insecticides in the farm, which is why I put him on his grandfather's farm in rural Mississippi. But aside from, we just don't see that very often, but it's acrodynia, skin findings, painful hands and feet, almost nothing else but the pink nose and the pink toes and fingers. And this is important. An 8-year-old boy presents with complaints of burning hands and feet, worse in the summer after exertion. He doesn't sweat. Family history: mother has one brother, age 42, who's on dialysis, and another brother, age 48, who has cardiomyopathy. What lesions would you expect to find on this child? Café au lait spots over the chest and abdomen, ash leaf spot, angiokeratomas in the groin region, or spider angiomas in the chest and abdominal wall area. Angiokeratomas, actually, is the right one. This is Fabry's disease. It's now become somewhat important because we have a treatment. Because it's an absence of alpha-galactosidase, which we can infuse. It presents early in life, just as the above. And the classic thing, I was in New Orleans and had 2 patients who lived down there and who didn't sweat. That in itself is abnormal, but they had the painful neuropathy. Later on, they developed renal failure and or cardiac cardiomyopathy. Enzyme replacement therapy is now available. And so you can prevent both the renal and heart disease and help a little bit with the neuropathy. What does that mean? I think you all recognize the rash. Just key in an answer. Correct. Insulin, as your insulin level goes up, for reasons that I don't totally understand, it stimulates melanocytes to produce pigment primarily in the neck and under the arms. And so when you see that, you know they've got increasing insulin levels. They're also at risk for type 2 diabetes, but it's clear that they've developed some insulin resistance. I'm going to show you a fundoscopic exam, and you're going to tell me what disease he suffers from. Asthma, bronchopulmonary dysplasia, cystic fibrosis, or reflux. And what I'm pointing to, if you can see this right there, as opposed to, Looks like specks of dirt in your fundus, in your ophthalmoscope. Go back, key in an answer. You may not have seen those. You have to really look for them. Actually, it's severe asthma, because those are what these are. Is steroid-induced cataracts. So, and they literally, when doing transplants, I used to look for those, and if I didn't see them, I knew they weren't taking their prednisone. Because after a year, you begin to see at least one or two. They usually don't interfere with vision, but they look like you've got a dirty ophthalmoscope. And they don't, at least I thought of cataracts as whitish, but these are little black dots. The boy in the next picture may have the following, except Coats disease, a history of trauma, I'm just running out of time, history of prematurity, or galactosemia. I won't even make you do that. Premature, with a birth weight of 1,900 grams, it's very unlikely that he has a cataract from that. But Coats disease, a history of trauma. Trauma is the most likely. Galactosemia is extremely unlikely unless he's been treated. And then this last lesion, I always forget the name of it, but history, this is a girl with Wegener's. She had a catheter placed for hemodialysis access. She immediately came back with a fever of 41 degrees, hypotensive, transferred to the PICU, and it was obviously septic. And then we saw this black lesion right here. And when Camille comes up to introduce the next speaker, he'll tell you the name of it. I always forget. But what's the organism? The organism is Pseudomonas. So that finishes it. I'm 1 minute over.